Okay, hello Brazil. So I just finished, I'm Brennan Spiegel. I'm a gastroenterologist at UCLA in Los Angeles. Just finished a discussion about treatments of irritable bowel syndrome, including both pharmacological treatments and non-pharmacological treatments. And some of the summaries of the discussion are that irritable bowel syndrome is a condition that has abnormalities in the brain and in the gut. We know that there's changes in both the abdominal function and in the brain function. And our treatments should be focused on both the brain and the gut. Some patients are more affected by their brain, some patients are more affected by their gut, and some patients are right in between. Today I talked about some of the different therapies that are available and talked about the evidence behind these therapies. For example, starting with very simple therapies, talked about different dietary approaches and the evidence behind them. Found that certain diets, like a gluten-free diet or a low FODMAP diet, which is a diet with a few fermentable oligosaccharides, can be highly effective in patients with irritable bowel syndrome, but we don't have a lot of data. I talked about peppermint oil, a very simple, inexpensive therapy that is highly effective in many patients. We talked about antidepressants, which also can be highly effective, and some of the differences between the antidepressants. We had a discussion about different tricyclic antidepressants, for example, amitriptyline and nortriptyline and desipramine. And we talked about how amitriptyline can be very effective for patients who have sleep disorders because it can help them sleep, and who have diarrhea because it can be constipating. So amitriptyline is often what I use early in patients with diarrhea, predominant irritable bowel syndrome, along with loperamide. So we talked about that and the data supporting it. We also talked about antispasmodics, and some patients with abdominal cramping and urgency can do very well with antispasmodics, and there are meta-analysis data that show that there are benefits for antispasmodics. Some patients with IBS do truly have a spastic gut. Their gut is tight and tense, and antispasmodics can work in many of those patients, treatments like dicyclomine or hyoscine. We also talked about some of the newer therapies, especially for irritable bowel syndrome with constipation. For example, lubiprostone and linaclotide. Lubiprostone is a chloride channel agonist, and what it does is it increases the movement of chloride into the lumen, which can help move water into the lumen, which is a good thing if you have constipation. There's data that shows that lubiprostone is effective based upon randomized controlled trials. Some patients can get nausea from it, but the nausea is relatively uncommon. Then finally, we talked about linaclotide. This is one of the newest therapies for patients with IBS and constipation. It's approved for IBS with constipation, and it also can be effective for patients with abdominal pain. Abdominal pain is one of the most difficult symptoms to treat in patients with irritable bowel syndrome, and linaclotide shows that it can improve patients' abdominal pain, and the data look very promising, very large effect sizes of linaclotide. So very enthusiastic about that medicine, but time will tell how effective it is. So that's a summary of an hour and a half of discussion. I hope that's helpful, and have a good evening, Brazil.